Hello, welcome again. I hope you're having a good day. This is going to be a talk about nutrition in the critically ill surgical patient, as well as management of special surgical populations and their nutritional needs. Again, the usual disclaimer of no conflicts of interest, and that this information is collected largely from my own personal experiences as a literature review in the summer of 2024. And there may be others, including your own personal experience, which is different but not less true. Checklist for stuff to do this week if you're in the Pediatric Surgical Care Fellowship. One in particular is to not use the word nutritionist if you can avoid it. They don't like it. It doesn't have any degree or accrediting body requirements. They like to be referred to as their title, which is RD, or Registered Dietitian. Now we'll go through some of the basics of nutrition in infants. In the first week of life, they'll lose about 5 to 10% of their body weight. In premature infants, that can be up to 15. They should regain that by about 2 weeks of age. General macronutrient requirements, 80 to 100 kilocalories per kilo per day, with about a third to half of that from fat, another third or half from carbohydrates, and then the rest from protein. Fluid requirements vary by size of the infant and the extremely low birth weight. That can be as high as 100 cc's per kilo per day, or up to 150 cc's per kilo per day on the first day of life, with lower amounts, as you can see in the table, for the very low birth weights, or above 1.5 kilos down to 60 or 80 cc's per kilo per day on that first day. They get fluid excess typically around the time of birth. And as their kidneys are maturing, if you give them too much fluid early on, that can cause some fluid overload issues. Gastroschisis babies generally go up 1 day for their fluid requirements. They have some fluid losses that require a little bit extra. General electrolyte requirements listed here for sodium, 2 to 6 milliequivalents per kilo per day, and listed under that potassium 1 to 3, calcium phosphate around 1. Pay attention when you're especially writing TPN for chloride to acetite ratio. Neonatal kidneys are kind of dumb and have problems concentrating, diluting, acidifying, or alkalizing the urine, and iatrogenic things like the chloride to acetate ratio in TPN can significantly alter the acid-base status. And then a variety of micronutrients, zinc, selenium, etc., multivitamin, also needed and included in formulas, or you'll have to put that into the TPN. Basics of enteral nutrition. Sometimes if they haven't had intestinal surgery, or if they recovered quickly, for example with a colostomy, you can immediately start ad lib breast or human milk or formula, especially if they're above 35 or so weeks, which is when the swallow reflexes develop. Indications for donor human milk vary by institution. In general, very low birth weight infants, extremely low birth weight infants, so those weighing less than 1.5 kilograms, and then additional indications, gastroschisis, which have increased incidence of necrotizing enterocolitis, those with post-necrotizing enterocolitis who have already had it once, and then with congenital heart disease. After surgery, when there is return of bowel function, which means that there is some, but you don't need all, some combination of pooping, belly soft, OG tube is output is less than 20 cc's per kilo per day and non-bilious, you can begin 20 to 30 cc's per kilogram per day and advance by that amount once or twice per day. Usually Q3 in newborns if you're doing bolus or PO feeding. Some full-term infants with very distal obstructive processes, once you divert them, you can go to ad lib very quickly and sometimes right away. Tube feeding. There is a higher risk of perforation with post-pyloric tubes in children less than 10 kilos, and so we tend to avoid them if possible, although it's not always. When you do the post-pyloric tubes, you can we'll be doing continuous. Otherwise, in general, unless you're shortcut, we'll be doing bolus feeding. Huge variety of formula types. Standard term formulas include Similac or Similac Advance, Enfamil, Good Start. There's some other Similacs, Total Care, 360, etc. There's Premi formulas, which is Similac 24, Enfamil 24. The 24 is kcals per ounce, as they require more calories. Anti-reflux formulas, unfamiliar AR, some sensitive. There's lactose-free and soy, as well as hydrolyzed elemental varieties for those who might have trouble with either nutrient absorption or milk protein allergies. These formulas or even human milk can be fortified to provide additional calories or additional protein if those are needed. Milk protein allergy is a spectrum of disease. There's IgE and non-IgE mediated reactions to food, most commonly cow's milk proteins. To know, along the spectrum are food protein-induced allergic procticulitis of infancy, which is FPIAP, and the infants in this case are generally well appearing, but they may have some blood or mucus inside of the normal or loose stools, and so this will sometimes generate a consult, for example, for necrotizing enterocolitis if there's an occult or grossly bloody stool in an otherwise well-appearing infant without any kind of concerning findings on physical exam or on ultrasound or x-ray. This could be considered. In food protein-induced enterocolitis syndrome, the infants are generally more symptomatic with vomiting, abdominal distension, sometimes temperature instabilities. It's a clinical diagnosis. There's not really any serum testing. There can be performed an endoscopy looking for eosinophils on biopsy, but that is not commonly done. More commonly, with enough clinical suspicion, the infant will be switched to a formula milk which doesn't have those milk proteins, or in infants on human milk, the mother will be asked to withdraw those from her diet, which can persist up to 2 weeks. It's not allowed to eat things like milk or cheese, etc. Allergies to the human milk proteins are much rarer. The majority of children achieve tolerance eventually. Basics of parenteral nutrition for infants. There's some institutional and individual dietitian variances to this. If you're at Children's Wisconsin, you'll have your own handbook, and I've included some Kansas City references in the Laird Learning Center. But basics, calculate a total fluid goal, subtract other drips. If you're on day 1, often students will have a starter TPN fluid, which is usually a D10 plus some amino acids and maybe some electrolytes or heparin to keep the lines patent. And then once a PIC or other central axis is established, move on to ordering more custom TPN. The initial glucose rate generally is 4 to 6 milligrams per kilo per minute, and then advanced to reach goal calories, which alongside lipid advancements, usually the goal calories alongside goal fluids are reached on around day 5. Lipids generally started around 1 gram per kilo per day and then advanced until at 3 while monitoring the triglycerides. There are many different types of lipids, well, maybe not many, but at least several. Most commonly for infants on short-term TPN, there will be intralipid, which has soy and some egg yolk phospholipids in older children that can sometimes trigger allergic reactions, hives to the egg protein, which is different. They will have nothing when they eat eggs, for example. There's also SMOFs, soybean, MCT, olive and fish oil, and omegavin, which is a fish-based, and those last two are for kids who are going to be on TPN for a little bit longer, and they prevent damage to the liver, alongside cycling with TPN to a non-24-hour. And then there's amino acids, given at 2 to 4 grams per kilo per day. Monitoring labs, electrolytes will be done daily until you're on goal, and then around once or twice a week in stable infants. And similar for triglycerides. If those are more than 250 or high, consider if it's being drawn from near lipid infusion, or whether or not the need to hold the lipids or compress them 20 hours a day, or decrease the amount that's being given. Historically, sometimes lipids were held for hyperbilirubinemia, but that's not generally done. Other things to monitor while on parenteral nutrition, the central line tip location. There is some institutional variance due to the small nature of the babies. A 1 to 2 centimeter drift from positioning can sometimes cause a central line to become not a central line, a peripheral. And so some centers will monitor that with routine weekly x-rays, for example. proper positioning of a umbilical vein catheter is at the IVC-RA junction. For a lower extremity venous access will be in the high IVC, upper extremity access in the distal half of the SVC, generally 1 to 1.5 or so vertebral bodies below the carina. Consider the need to prevent blood clotting, especially if the cannula size is relatively big compared to the vessel, whether or not you need prophylactic or therapeutic anticoagulation to prevent thrombotic complications while that line is in place. Coming off of TPN, generally this means you are starting enteral feeds, and so calculate the amount of cc's per kilo per day that you're expected to be able to take, and then decrease the TPN accordingly, making sure that you're not just decreasing the volume, but your glucose infusion rate, etc. You can, if you're not sure how much the infant will actually take of what you order a little bit more TPN, and then simply dial that back later in the day. It's easier for the pharmacist to make a bag than for you to change the rate of the drip, than to have the infant not tolerate your diet and then have to order supplemental fluids. When weaning, you'll generally reach a point usually around 60 cc per kilo per day of enteral feeds when TPN, of parental remaining IV given fluids. And at that point, the TPN tends to have trouble concentrating enough to supply the lipids, amino acids, and the carbohydrates. At this point, if you can, increase the enteral feeds faster, and there's preferences for what to do with the remaining fluids. Some drop the lipids and continue to provide amino acids and carbs, which results in more protein. You can also do lipids and lights, continue the lipids, run a D10 electrolyte solution, and the lipids more calorically dense than the proteins and carbohydrates, which will result in more calories overall being given. Special populations in the NICU and their nutritional needs. We'll go through a couple of those, as well as some in the PICU. But first, a word on TPN and why it's the devil. So surgical training is rather anti-TPN, and this goes back all the way almost to the year 2000 before. This is a review table recommendations from the American Gastroenterological Association, which was a review of over 100 randomized control trials, which failed to identify any benefit to parenteral nutrition in those expected to resume enteral nutrition less than 14 days. There was 1 or 2 exceptions for preoperative nutrition for upper GI cancers, for example, esophageal cancer. Some of the studies they reviewed even found that TPN before that 14-day time was harmful. What evidence do we have from the adult literature? Cesar, New England Journal of Medicine in 2011, the EPaNIC trial of 4,500 patients concluded that late initiation of parenteral nutrition was associated with faster recovery and fewer complications as compared with early initiation. Vermont in Current Opinion of Gastroenterology, 2014, a meta-analysis concluded the best available data that critically ill patients would be started on enteral tube feeds within 48 hours of intubation whenever possible. This was for ventilated patients specifically. The use of parenteral nutrition should be limited within the first 6 days, and there was similar benefits to minimal trophic enteral feeds versus full caloric nutrition. So ASPEN, which is the American Society for Parenteral and Enteral Nutrition, joined with SCCM to provide these guidelines for provision and assessment of nutritional support therapy, which is from 2016. And you can see we suggest that in a patient at low nutritional risk, exclusive parenteral nutrition be withheld over the first 7 days if the patient cannot maintain their intake, and if early enteral nutrition is not feasible. Use of supplemental TPN should be considered after 7 to 10 days. Prior to that, it does not improve outcomes and may in fact be detrimental. Additional, more recent paper from 2013, among patients who cannot receive enteral nutrition, the general consensus is that you shouldn't do it until at least 5 days. After 14 days, you should definitely do it. In between 5 and 14 is less clear. But that's all adults, right? We know kids aren't just adults. Well, we have, in contrast to the EPaNIC, a PEPaNIC in New England Journal of Medicine 2016, which was a multi-center trial, randomized controlled, almost 1,500 patients admitted to the ICU, all the way from full-term newborns until 17 years of age, and they were randomized to an early group, parenteral nutrition initiated within 24 hours of admission, versus late, where parenteral nutrition was delayed up to the morning of day 8. These patients were fluid matched using D5NS, unless they were hypoglycemic, in which case they got D10. And the results were that there was similar mortality. The late parental nutrition group had superior overall outcomes, including fewer newer infections, a shorter ICU stay, a higher likelihood of discharge alive from the ICU, shortened mechanical ventilation, and a shorter total hospital duration of stay. But infants aren't just little kids, right? What about the very little ones? Post hoc subgroup analysis of the 209 term neonates less than 4 weeks of age revealed that the benefits of delaying it again were not only there, but possibly greater than. Well, but my patient's malnourished, though. Well, I did another analysis and republished it in JAMA in 2018, finding that in that same group, undernourishment had some risks and increased odds of complications, but the late parental nutrition to that group also had similar benefits of shorter infections, shorter duration of ICU stay, and they concluded that even in the undernourished critically ill children, withholding parental nutrition for 1 week was clinically superior to early parental nutrition. And one last little paper here, early parental nutrition in critically ill children who were not receiving early enteral nutrition, about 2,000 patients, children not receiving enteral nutrition within 4 days of ICU admission. Those who received TPN within 48 hours had a higher mortality with an odds ratio of about 2. It's pretty high. Just adding to the volume of pediatric literature and adult literature, suggesting that we shouldn't be as cavalier with starting TPN within those first 7 days. All right, let's talk about some special populations. Intestinal failure and short bowel syndrome. What is intestinal failure? This is intrinsic intestinal disease resulting in the inability to sustain growth. Aspen defines it as patients receiving TPN for 60 of the last 74 days. The majority of cases of intestinal failure are caused by short bowel syndrome, of which there is a subset, ultra short bowel syndrome, which is the loss of more than 90% of the small intestine. Other causes of intestinal failure, congenital mucosal defects, and chronic intestinal pseudo-obstruction. Nutritional management in this population, human milk is a preferred initial form. If not available, use of amino acid elemental type formulas has been associated with attaining earlier enteral autonomy. Enteral feeds can be advanced as long as the output is less than 2 cc's per kilo per hour or 25 to 30 cc's per kilo per day. And there's a variety of medications to slow down the output, loperamide, cholestyramine, pectin, etc. Usually be a G-tube in place. Sometimes they'll be requiring continuous feeds, and then with TPN to supplement the remainder of their nutritional needs. Depending on how long they're on that TPN, you can certainly have complications due to both the central line as well as the TPN. So things like clots, infections from the central line, and then liver complications, including cirrhosis and liver failure. As we mentioned earlier, SMOF, omegavin, fish oil type formulations can delay and prevent those complications from happening. These infants and children with intestinal failure are also prone to metabolic bone diseases. Eventually, about 50% of infants with 35 centimeters can fully transition, 35 centimeters of small bowel. Some patients with only 10 to 20 centimeters of small bowel can transition also eventually over the course of years to full enteral nutrition, especially if they have a little bit of ileum in their colon. The non-shortcut infant following intestinal resection or diversion who's failing to gain weight. Weight gain can be a result of needing more calories, or it can be a result of needing more sodium, and this is a landmark surgical paper, Buttersworth in 2014, found that urine sodium correlates to weight gain, even in those with normal serum sodium. And so if the infant that you're seeing is not gaining weight, but you feel you're giving enough calories, check a urine sodium. And if it's low, it'll be replaced with enteral sodium, usually 4 to 6 millicorrelates per kilo per day, and then weekly repeat and taper when it gets back to above 50. CDH. Failure to thrive has a high prevalence in CDH survivors, up to 70%. They have the possibility of catch-up growth later in infancy, but they have a hypermetabolic catabolic state with feeding difficulties and reflux and oral aversions that puts them at risk for poor weight gain, and may require up to 25% more calories in order to have optimal weight gain. Congenital nephrotic syndrome, massive proteinuria, hypoalbuminemia, edema. They can have hypercoagulability and thrombosis as a result of antithrombin 3 deficiency, as well as immune dysfunction. How can you help manage this? Might need albumin infusions, potentially daily, diuretics, fluid and salt restrictions. In the past, historically, there were recommendations for high protein, high calorie diet, but that has since kind of faded. Additional perioperative concerns for G-tube, PD catheter, nephrectomy, transplant, things you might be asked to do, that there might be tissue edema, hypercoagulability, ascites. Consider the potential need for hemodialysis when considering vascular access. If you are asked to do a PD catheter, assess whether or not they need a feeding tube and any hernias fixed as well. All right, so let's talk about some nutritional considerations in the premature and necrotizing enterocolitis populations. So preterm infants do not develop swallow reflexes until 34 to 36 weeks corrected. Prior to this, they need to be fed via an OG tube, usually either fortified breast milk or preterm formula, which has higher calories. Post-necrotizer enterocolitis, there's institutional variability with the type of feeds and feed advancement, as well as the duration of NPO time, with some more recent literature suggesting that the traditional 7 to 14 day courses may be too long, especially in the bowel stage 1 or 2. Typically, post-necrotizing enterocolitis, I'll start around 20 to 30 cc's per kilo per day, and then advance by that amount, looking for intolerant as a sign of either recurrent neck or some neck stricture. All right, gastroschisis and how to feed them. Not one optimal way. A lot of institutional and surgeon variants in this as well. In Kansas City, for example, the infants were fed as soon as the intestines were inside the abdomen. When I trained in Milwaukee, we had waited 5 days before going on to a protocol. Once you do start, generally advance by 20 to 30 cc's per kilo per day is tolerating. I try to do this, if possible, by mouth. I feel that in gastroschisis and congenital heart disease and other infants at risk for higher risk for necrotizing enterocolitis, allowing them to regulate their own feeding can give some increased awareness that when they aren't taking their full volumes, that their bellies don't feel so good. Whereas if they're force-fed via NG-OG, they don't have that break option. Keeping in mind that there is an increased rate of neck in the gastroschisis population of around 10%. They will sometimes qualify for donor breast milk as a result of that. The neck in this population has been some of the most severe I've ever seen, and so I tend to be a little more cautious with feed advancement as well as with tube feeding. All right, next population, congenital heart disease and pulmonary hypertension, pulmonary recirculation, silent heart diseases, etc., associated with more frequent enteral feeding difficulties, moderate to severe malnutrition, low weight gain, higher need for G-tubes. They are high risk for neck, although whether that's actually necrotizing enterocolitis or some other form of intestinal ischemia, such as non-occlusive mesenteric ischemia, which has similar end consequences of dead bowel, but may not be a dysregulated inflammatory cytokine toll receptor mediated pathway that is the true necrotizing enterocolitis. Moving on to the PICU, screening for malnutrition. So lab markers are pretty useless. More important things, history, physical, findings of muscle wasting or weight loss, muscle mass on imaging is better than lab markers. There are screening tools which are validated in the pediatric surgery population, strong kids in the PNST. You can also ask your dietitian to help with this if you have a patient who you're worried about. What to know nutritionally for your Crohn's IBD patients in the PICU if they have presented in toxic megacolon, or in an extremely depleted state nutritionally, they may be at risk for refeeding syndrome. They'll be at higher risk for complications, including surgical complications. They may also be on chronic steroids and have disordered ileoabsorption of A, D, E, K vitamins and B12 deficiencies due to involvement of the terminal ileum in their disease. They may also be on exclusive enteral nutrition, although that's becoming less frequent now. That is a liquid formula-based treatment for Crohn's, which has pretty good success with treating severity of disease, although poorly tolerated, especially in pediatrics, because it's a kind of depressing diet. Burns, and this will be talked about as well during our burn talk, but good to know and good to go over again. Early entry nutrition, just like in most of the ICU population, improves outcomes in pediatric burn patients. What does early mean exactly? Is it the first 4, 24, 48 hours? It's not really terribly clear. I usually think of it as somewhere in that 24 to 48 window. And then what counts as nutrition? So these burn populations should be on a low-fat diet with lipids less than 1 gram per kilo per day. They have a hypermetabolic response, and that inhibits lipolysis and limits the use of lipids for energy. They should be on a high-protein diet, although there's not strong evidence to support exactly how much, and there was some publications that supplying more than 2.5 grams per kilo per day increases urea nitrogen production, but also that same population had improved skin healing. So in general, try to give somewhere in that range. The calorie requirement may be increased by up to 50%. What counts as a burn? Generally, this nutritional talks are for patients in the ICU, and those are usually at least 20% total body surface area of second to third degree burns, their former name, or superficial partial thickness to full thickness burns is their current nomenclature. How should it be delivered? PO, NG, NJ. If they're able to tolerate PO, that's great, but they will often have reduced PO volumes and require some form of tube feeding. If they're going to be going back to the OR frequently, I prefer to have a post-pyloric tube so that you can do uninterrupted perioperative feeding, which has proven safe for the last 30 years. They have dysregulated carbohydrate metabolism and will often be hyperglycemic, especially for the first few days with insulin resistance. And they can have a persistent hypermetabolic state into the rehabilitation phase lasting years, which we typically treat with beta blockers. And we used to with oxandrolone when it was available. It's no longer. Trauma. Brain injury foundation, level of recommendation. Again, early entry nutrition, in this case, they defined that as within 72 hours improves outcomes. In general, in your ICU population, if you're asked a question about early entry nutrition, it's best to go ahead and give early entry nutrition unless there's an absolute contraindication for it. It almost always improves outcomes, even at trophic levels. For non-TBI trauma in the PICU, relatively paucity of data. The 2010 Seminars in Pediatric Surgery summary was to feed early, but not too much, but enough protein, but going through the gut if possible. They had a question of special formulations, which has now fallen out of favor of the immunomodulating formulations, etc. Adult trauma in pediatric ICU data, similar to what we previously talked about, withholding parenteral nutrition for the first week, starting early entry nutrition if possible, and similar outcome benefits from trophic versus full enteral feeds. Other illnesses in the PICU, respiratory failure, etc., initiation of early enteral feeds within 48 hours of PICU achievement and up to achievement of 2/3 of the nutrition goal in the first week has improved clinical outcomes. As we mentioned before, immunonutrition is not really recommended. Pancreatitis. Incidence of this seems to be increasing worldwide. You may be seeing it more commonly. In 2018, the European and North American societies joined together to release guidelines. There's not really much pediatric data, so they extrapolated adult data and said go ahead and do early entry nutrition within 48 hours. It has significant reduction in mortality, which is supported by the small amount of pediatric data available. Oral versus NG or transpyloric tubes were all okay. After 5 to 7 days, you can consider parental nutrition. They did not have enough data to make recommendations instead of pancreatic injury, pancreatic trauma, ductal injury, etc. And then a special mention for fluids, because historically, infants, children, adults with pancreatitis were given a heck of a lot of fluids. And even in these 2018 guidelines that recommended up to 2 times maintenance with boluses as needed for hemodynamic compromise. No recommendation for colloid. The New England Journal of Medicine recently had a study called Waterfall, in which they've kind of backed off a little bit of those fluid suggestions for adults in that case with pancreatitis, joining with data from a movement in the rest of critical care trying to move away from fluid overload, which has been shown to worsen outcomes. Nutrition in ECMO. It's challenging. They're at high risk for both over and underfeeding. Total energy expenditure is not well understood. They may be on inotropic or vasoactive support, which may limit the ability for enteral feeding and have reduced gut perfusion barrier function while on ECMO. That being said, again, early enteral nutrition, in this case by day 5, seems to have improved survival to discharge if it is possible to do. And this is one of the special populations in which you might consider early initiation of parental nutrition, TPN. All right, refeeding. Who's at risk? Kids with non-accidental trauma or abuse, inflammatory bowel disease, or if they have a history of weight loss or oncology. Other signs, symptoms, labs, imaging warning signs. If you see a hypoattenuated liver, a liver that looks almost fatty, but the patient is not obese, that could be a sign of starvation. Management. So before feeds, check electrolytes, particularly phos, mag, and K. Start vitamin supplementation, and then increase feeds gradually, starting with initially maximum of 40% of the goal, while checking those lights at least Q12 hours for 3 days, while doing vital signs and cardiac monitoring. There is some suggested readings. Nutrition is a very important topic, and there's a lot here. Go over a little quiz. Neonate having intestinal surgery is struggling with weight gain despite seemingly adequate nutrition. Which labs should you check? Urine sodium, serum sodium, hair sodium, or air sodium? In this case, urine sodium, which can show signs of depletion even if blood or serum sodiums are maintained. The child is admitted to the PICU and has contraindications to enteral feeding. Parental nutrition should be started within the first 24 hours, 48 hours, or the correct answer has not been shown to have benefit and may cause harm when started in the first week of NPO, even in the malnourished patients. A child with 50% burns is admitted to the PICU. Enteral feeding should be started within 24 hours, should be delayed until the child fails to demonstrate adequate PO, should not be started. Instead, give TPN. In this case, unless they're on extreme resuscitation requirements, you should give early enteral nutrition. Ideally, since we're going to the OR probably pretty frequently, through a transport tube.